Swati, join?
Yes, sir. Hello. Can you listen?
Yeah, yeah.
Sir, shall I start? Okay, sir. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar organized by AMOX Fetal Medicine Committee and Aurangabad OBGY Society. It's my privilege to welcome the MOC of today's webinar, Dr. Swati Parihar ma'am. Ma'am is the consultant obstetrician and gynecologist at St. Anne's Hospital, Aurangabad. Ma'am is the ex-registrar at Holy Family Hospital, Delhi. And ma'am has worked as a gynecologist at Fortis Law MA, Delhi. And ma'am is the winner of Rishikesh Pai and Reshma Pai quiz and also the winner of West Zone Yuva Foxy quiz. And ma'am's areas of interest are high-risk obstetrics and infertility. I welcome you, ma'am, and I hand over the session to you.
Thank you so much. Thank you for the kind information. Can we move on to the slides? I welcome to today's webinar everyone, all delegates, all faculty members. Today's webinar is organized by Dr. Sujit Konkar sir. He is a Fetal Medicine Committee AMOX chairperson. I would like to invite Dr. Sujit Konkar sir to welcome all delegates and to share the details about today's webinar. Dr. Sujit Konkar sir has done his MD OBGY from the GMC Aurangabad. He has done his USG training under Dr. Bimal Sahani sir. He is FMF certified 11 to 13 week scan for P screening, Doppler, ultrasound, and fetal abnormalities. He's a secretary of the Society of Fetal Medicine, Marathwada chapter. His Shri Hospital is Foxy approved for USG training. He's interested in the advanced fetal ultrasound, and at present, he's a chairperson of Fetal Medicine Committee. Welcome, sir.
Thank you, Dr. Swati, for nice introduction. Good evening, respected seniors, dear friends and colleagues. I am very much pleased to welcome you all. I invite and welcome our chief guest today, Dr. Gokul Das sir. We need our blessings, sir. Your blessings, sir. I invite and welcome our guests of honor today, Dr. Priti Kumar madam and Dr. Abharani Sinha ma'am. We are eagerly waiting for your words of guidance. I welcome AMOX President, respected Dr. Rajendra Singh Pardesi sir, who has been constant source of inspiration and guidance to all AMOXians as well as all Foxians. I welcome our chairpersons today, Dr. Varsha Lahade ma'am, Dr. B.S. Jodha sir, and Dr. Leela Vyas ma'am, who are interested in your special remarks after the talks. I welcome our President, Aurangabad OBGY Society, Dr. Aparna Rao, for this webinar. And I invite and welcome most important players today's speakers, Dr. Raju Giradi, who is going to talk on understanding multiple duct anomalies, Dr. Aarti Deendayal ma'am, who is going to talk on ultrasonography in infertility, and Dr. Tejasri Patekar, who will enlighten us about the intricacies of follicular monitoring. Welcome all delegates who have logged in for this webinar, and I request Dr. Swati to take over the session.
Thank you so much, sir. Moving toward our sessions, I would like to invite and introduce our today's chief guest, Dr. Gokul Das sir. He is a past vice president Foxy, and he is the president of IMA Guwahati. Welcome, sir. He's MD, FICMCH, FICOG, OSD Shrimanta Shankar Dev University of Health Science Guwahati, Assam 2020. He's a founder, professor, and head of obstetric gynec department, TRIMS, Arunachal Pradesh. He's a professor and head of department of Guwahati Medical College. He's a vice president, Federation of Obstetric Gynec Society of India, member of governing body ACOG. At present, he's president of Guwahati OBGY Society, president Association of Obstetric and Gynec Society, Assam. He delivered a guest lecture oration panelist in national and international conferences. He has published his chapter in Foxy Publications and published article in national and international journal. Welcome, sir.
Thank you. Thank you for such great introduction. I don't know, but then I'm very friendly with most of the faculties of Aurangabad, and I have visited Aurangabad a number of times. And this today's discussion is really very beneficial because ultrasound is the basic modality nowadays, and it gives us so much of information. And today's discussion will be focused on Mullerdach anomalies and also in infertility and follicular monitoring. And all these are very essential in management of infertility. And I'm sure emerging sciences have really progressed tremendously from its inception way back in the 90s. And now we can really look forward to a lot of developments and a lot of applications. So I wish you all the best, and eagerly waiting for the speakers to their great lectures and then participation by the delegates. And thank you very much for such point. And then blessings are always there. Thank you so much. Thank you very much.
Thank you so much, sir. We are blessed to have you here on this webinar. I would like to invite our guest of honor for today's session, Dr. Preeti Kumar and Dr. Abharani Sinha. Slides, please. Slides. Next slides. Dr. Preeti Kumar, she is a chairperson of Maternal and Perinatal Committee FOXY Committee, chairperson of Safe Motherhood Committee. She is a committee member of MFM Committee, Joint Secretary of Indian Justices Chapter. She is a professor and head of Department of OBGY and Narayana Institute Medical Science, Kanpur. She is organizing secretary of Lucknow, Vice President Lucknow OBGY Society 2022, core member of Prevention of Violence Against Women Cell FOXY, recipient of Shining Star Award Lucknow OBGY Society. She is a recipient of...
Let's not waste time. Thank you so much for the kind introduction. And it's really pleasure and honor to be here with Gokulda. I think he's a faculty par excellence, and we, look forward to him for, so many things. And I'm especially thankful to Dr. Rajen Singh Pardesi, sir. He's an inspiration for all of us. And I must tell you that he's the person who pushed me into FOXY. He was the first one to, push me into FOXY. So thank you, Sujit and Dr. Sujata for inviting me here. And I've joined from Imphal because we are here for ISO-NIVA FOXY conference. And just one thing I want to tell you, as Dr. Gokulda has already said, that these things are very important, Mullerian duct anomalies and ultrasound. But still, as an OBGYN, when I'm working as a Safe Motherhood Committee chairperson, I still feel that a lot of, FOXY members need training on first trimester scanning, which is, the inverted pyramid of antenatal care. We need to detect more of anomalies in the first trimester. So I'll request Sujit to focus more on the training part in the first trimester, because that is really very important. This is the first time that every OBGYN puts a probe inside to confirm the pregnancy and just to see the fetal heart and how the things, work. So, Sujit, I think you should work more on the first trimester scan. This is a really useful topic for all the OBGYNs. And we as OBGYNs need to learn a lot about the hands-on training, maybe simulation drills, because a lot of, companies are doing simulation exercise like trainings like Wipro and all. So you can take it up instead of these webinars, you can just have simulation sessions on these trimester scans. This will be really, very, very helpful for the participants. So thank you so much, and high regards for Gokulda and Abhaji, and all the faculty wish you all the best luck for this session. Thank you so much.
Thank you, ma'am. Thank you for kind word of wisdom. Inviting our next guest of honor, Dr. Abha Sinha. Dr. Abha, ma'am, she's MBBS DGO MS FICOG, Professor and Head of Department of Muzaffarpur, ICOG Governing Council Member 21-22, President Patna OBGY Society. She's Chairperson of Quiz Committee FOXY 15-17, National Corresponding Editor of Jogi, PG and teaching experience more than 26 years. Contributed chapters in a FOXY publication. She's a Joint Organizing Secretary of AICOG 2014, Master Trainer of FOXY. her high risk, special interests
Thank
are
you,
in high
Swati.
risk
I think
pregnancy.
this is enough. Thank you, Swati.
Yeah,
Thank you.
thank you, ma'am. Welcome,
Thank
ma'am.
you. At the outset, I'd like to thank the AMOG's Fetal Medicine Committee for inviting me and giving me the honor to be the guest of honor for this prestigious program. I'm so glad to see as the chief guest, Dr. Gokul Chandra Das. As Preeti has rightly said, we have a lot of regard for him. I'm also happy to see Preeti as the guest of honor. And Dr. Sujit, he has been coordinating this program. So thank you, Sujit, for inviting me. And today, I think we have a very good session on fetal medicine where we are covering all aspects, right from Mullerian duct anomalies to ultrasound for infertility to follicular monitoring by ultrasound. So I think we are going to have some very good speakers like Dr. I think the first one is Dr. Rajiv, and then we have Dr. Aarti, and then Dr. Tejashri, and we have eminent chairpersons, Dr. Varsha Lahade, Dr. B.S. Jodha, and Dr. Leela Vyas. So I think we are going to have a very good learning session. So my good wishes and blessings are for this seminar. And once again, thank you for giving me this honor. I'm really honored to be the guest of honor today. Thank you so much.
Thank you, ma'am. Thank you for kind of words of wisdom. I would like to invite Dr. Rajendra Singh Pardesi, who is mentor of our Aurangabad Obstetric Gynec Society. I would like to invite him. He has presented 28 papers, 21 national and 7 international, 7-time best paper awardee, Foxy. He was a faculty in national and international conferences like Taipei and...
It's okay, Swati. It's okay. Respected Dr. Gokul Das sir, our chief guest. We are feeling proud to have Dr. Gokul Das sir, a legend in our OBGY field, is our chief guest. Then respected our guest of honors, Dr. Preeti Kumar, Dr. Abarani Sinha, and our AMOG's office bearers, and our president of OBGY Society, Dr. Aparna Rao, and secretary, Dr. Shraddha Paritkar. First, I wish to congratulate Dr. Sujit Kondkar, convener, and Aurangabad OBGY Society for organizing this webinar on fetal medicine. As Dr. Preeti and even Dr. Gokul Das told that now fetal medicine or ultrasound is the third eye of obstetrician. So we should be trained. So with the stalwart in this field like Raju Giradi, Dr. Aarti, Dr. Tejasri, Dr. Varsha Lahade, Dr. B.S. Lodha, Dr. Leela Vyas, and our MOC, Dr. Swati Pariyar, I think this is going to be a great event. I wish every success to Dr. Preeti Kumar and Dr. Abarani Sinha for their future endeavor in Foxy as Vice President. And same time, I wish every success to Dr. Sujit Kondkar and Dr. Varsha Lahade for their future endeavor in Foxy as Chairperson. Wishing every success to this great event. Thank you. Thank you so much for inviting me.
Thank you, Pardesi sir, for your good wishes. I know you're always with me. Thank you so much, sir.
Always.
Thank you, sir. I would like to invite Dr. Sujata Darvi, ma'am. I think she's not with us. Hello. Dr. Sujata Darvi, she's a consultant obstetrician, Gynec, Mumbai. She is honorary clinical associate, Nauroji Wadia, and Jagjivan Ram Railway Hospital, secretary AMOX, joint secretary editor Jogi, and clinical secretary Mumbai Obstetric and Gynec Society. I think she has not joined.
Yeah, not joined.
Yeah. Can we move?
Yeah, move on.
Yeah. I would like to invite our president of Aurangabad Obstetric and Gynec Society, Dr. Aparna Rao. She has done her MBBS, MS OBGY from MGM, DNB, MNS New Delhi, core fertility specialist in Aurangabad International IVF Center. She's practicing consultant since 25 years. She has received a Young Scientist Award, AICOG Hyderabad and Siliguru. Has received Young Gynecologist Award at Asia Congress Malaysia. She's faculty and presentation at various national and international conferences. Welcome, madam.
Thank you, Swati. I'm supposed to speak. It's better we start the scientific contents. I'm just eager to listen to all these talks of day-to-day interest in our practice.
Okay.
And I wish all the best to all of you and especially to Dr. Kondkar for holding such nice webinars very often. Thank you so much.
Thank you, ma'am. Thank you so much, ma'am. Moving toward our sessions, today's first topic of our session, I would like to invite chairpersons for today's session, Dr. Varsha Lahade, madam. Dr. Varsha Lahade, she is the president of Nasik Obstetric Gynec Society 22-23, zonal coordinator of AMOX. She is a past organizing secretary of Nasik, past joint secretary of IMA, National Faculty for Justices, and director of Prayag Hospital, Nasik. I would like to invite ma'am and give her introduction about our first speaker, Dr. Raju Giradi, sir. Welcome, madam.
Yeah. Good afternoon, everyone. It's my proud privilege to be a part of this platform. Congratulations to Dr. Sujit Kolkar. He has wonderfully planned the CME. Am I audible? Yeah. Regards to Dr. Gokul Das, sir, then Abharani Sinha, madam, Priti Kumar, madam, Dr. Rajendra Singh Pardeshi, a true leader, which I have already experienced that he backed us so greatly during the AMOX tenure, and I congratulate for this webinar. And can I have the CV of the next speaker? Yeah. So we have with us Dr. Raju Giradi, who is an obstetrician and gynecologist, junior consultant at Betradur Hospital, Raichur, Karnataka. He's a fellow in fetal medicine. His area of interest are pelvic imaging, fetal medicine, and high-risk pregnancy. Wonderful CV, Dr. Raju. Yeah, I hand over the mic to you for your talk. Thank you so much.
Namaste, ma'am. Thank you so much for the kind introduction. Sir, shall I start sharing the screen?
Yeah, please share your screen.
Is it seen, sir?
Yeah, yes, right.
At the very onset, I would like to thank the AMOX Fetal Medicine Society and the associated... Ma'am, sir, am I audible, sir?
Yeah, you are audible. Yeah.
The Aurangabad OBGY Society for giving me this wonderful opportunity. And I want to especially thank Sujit, sir, for giving me this great opportunity. I am really honored to be present among the august audience and my beloved teachers. So, moving with the topic, today we shall be discussing on gynec aspect in fetal medicine. Yes, why is it important? So we all know when we think of a Mullerian anomaly, we always think that it is the 3D which is going to stand out. So today I will touch upon that area because now infertility being on par with any others, and that we are screening every lady meticulously with our scans. So what is that in 2D will help us that we have to go and detect that we will be able to define that there is a Mullerian anomaly in that, and how better we can do that in 3D. So here it's not always 3D that we have to always depend on. It is our 2D which is going to play a very important role in diagnosing such cases. Once you got the hint, maybe you have to go for 3D, and 3D helps in quantification in some of the cases. That is how it helps. So before knowing how to look into the pathologies, so we'll start with the basic scan. That is how transvaginal sonography has to be done. So why am I taking TVS? Because it is the most common entity that we do on these population, especially in the reproductive age group. Maybe we have to do a TAS in young adolescent group or those who are unmarried. They usually present with some complaints. When you don't have a complaint, when infertility is the issue, we go for TVS. That is why I'm stressing more on TVS. Oh, it's not playing. The screen is not moving.
Sir, can you please click on the screen once and can you move it? Sir?
1 second. No. It was moving actually.
Sir, can you try once again now, sir?
I have to wait for a long now. Sorry.
Sir, can you stop share once and can you share once again?
I'm sorry.
Not able to share.
Sir, it got hanged, sir. I am just reopening it.
Yeah, Dr. Raju, you can share your
Sir, you can send it to
presentation
me so
to
that I can share,
Swati
sir.
or the shield person. You can share and then you can talk. Share your presentation to her, Swati.
Can we then shift toward a second
Post.
presentation
One
and then
second.
come back to
Swati,
first?
just wait for a moment. Wait for a moment.
It is opening 1 second. So.
Okay, okay.
Is it seen, sir?
Yeah, now it is seen.
Yes, yes.
Make it full screen now.
Yeah. So this is the first imaging that I want to show of a basic transvaginal sonography. This is how we should do our initial transvaginal sonography, that it has to begin from the introitus. As the word hysteroscopy goes, it is a misnomer. Hysteroscopy is not only looking at the uterus, we do it from the vagina. In the same way, transvaginal sonography has to begin from the vagina, from the introitus. So in this scan, I'm trying to show you, I'm going slowly into the vagina. I'm able to see the bladder here and the urethra. And once I go slowly, I try to place my probe. I hit the cervix there. I try to place my probe in the anterior fornix. So once I do that, I got to know this uterus is in anteverted and anti-flex position. I keep my sector width at almost 180 degree, and I try to take enough depth so that my interest is going to be occupying more than 80% of the screen. Once I've done that, I am trying to assess the cervix now. I try to assess the cervix, the anterior lip, the posterior lip, the cervical canal, and the endometrial lining, which is seen. So now I'll try to see at the counters of the uterus and try to compare the myometrial echoes with the rest of the uterine, like endometrium and all. So now I'm trying to play with my sagittal sweeps. I go towards the right side, then I come back to the middle, then I go towards the left side. These are my sagittal sweeps in the sagittal section. So in this, I'm trying to see any pathologies that you're having in the myometrium. For me, for understanding today's topic, this view is very important, where I'm going for the transverse sweep. Here I'm trying to assess the endometrial lining such that I go from the fundus. This is a fundus, the uterus, the lining is getting stretched. As I go towards the cervix, I go down, I go towards the cervix. I see some Nabothians there. Then I reach the cervix. Once I have done that, again, I'll come back towards the fundus. While am I doing this, I'm trying to see whether the endometrium is getting in continuity as a whole, or is there any bifurcation, or if there is any dimp in the serosal borders. This I'm going to stick only my uterine examination. So because of the topic today, I'm not going into the adnexa. This plays a very important role for all our future, whatever I'm going to show you, because the SAG views and the most important, the sagittal views, are the two important views that we need to define them properly, so that we will be able to find out some any pathology that we are going to encounter. So for example, the first case, we all know this. I'm trying to play the first case which I'm trying to show you. Look here, I have gone into my SAT sweep onto the right side. This is towards the right corner. When I come back, the endometrium is coming back towards the middle. Then I go towards the left side. What is that you are able to see in this case? You are able to see that the endometrial lining are closely approaching towards one corner of the uterus. That is onto the right side, onto the left. But when I take my transverse sweep, definitely you are able to make out two endometrial linings. They are getting bifurcated, that they are separate within the uterine cavity. So when I go towards the mid body, they are getting unified. As I go towards the cervix, yes, it is in the tubular shape. So when I come back again, they are getting bifurcated towards. they're getting bifurcated. As I come towards the fundus, yes, they are well within the uterine cavity. So one important thing we all got to know, we got that in this case, there is bifurcation of the endometrial linings. So we would have got the diagnosis now. For me, that is not important. We just don't have to look into the endometrial lining. I will just show you two important bookmarks in my case. The first one is this. Sorry. First one is this. See, in my sagittal sweep, when I came back to the middle of the uterus from my right side to the middle, you could see the endometrial lining is stopping here. Whereas my myometrial serosal counter is in its regularity, and this endometrial lining is far away from the middle. So you don't usually find such a wide distance when you have a regular convexity here. The endometrial lining is just stopping in the middle. So look here, this echo is in comparison with the myometrial echo, though it is more echogenic, it is likely a septate uterus. For example, if this would have been a bicornate uterus, you would have had a dimple over here, or you would have had the echogenicities of this bowel or the peritoneum, or the reflection of that or the omentum to be reaching till here. One more important I want to show, this is the first clue when you do your transvaginal sonography in sagittal view itself, you will be able to define, okay, there is a Mullerian anomaly in this. One more important, when I go here at my sagittal, the transfer sweep, look here, these two endometrial linings are getting bifurcated. Okay, this is the first hint. For me, that is not important. For me, what is more important is keep looking at the serosal border or the uterine counter here. If this uterine counter is maintaining its integrity along or the convexity along throughout the entirety of the bifurcation of the endometrial linings, yes, then it is a case of septate uterus. So that is why I'm trying to look at the endometrial serosal linings. So the uterine serosal linings, if they're maintaining their convexity throughout, even if the bifurcation of the uterine horns or endometrial horns are wide apart, then it is a case of septate uterus. For example, this case, when I go for a 3D, oh sir, I am not knowing what is it is hanging, sir. This is not happening. Sir, I'm very sorry. This was not happened.
I think there is a lot of information hidden in your PC.
Sir, it's open. I just share the screen. Okay, I'll just come back. This is the first video, this is the second video. And the same case, when you do a 3D for that, this is what you get. So for me, what is important is look at the serosal lining. Look at the serosal linings. This serosal counter, this is maintained. Most of us, when we look at the 3D diagram, 3D pic on the coronal view, we only look at the endometrial bifurcation. We don't look at the serosal borders. If this is maintaining in its convexity, even if the endometrial linings are wide apart, then it is a case of septate uterus. So why am I dealing with septate uterus a lot is because it is the most common entity and most common entity associated with pregnancy poor outcomes. That is why you can have a broad based, you can have a thin septa. Sometimes even this here is a regular, this here you can have a convexity. There it might have a fundal indentation, but this is not defining the bicornate entity, which I will be dealing later. Small indentation in the fundus also can be your septate uterus. So, okay, look at this picture. Why am I trying to show this? See, you have widely separated endometrial linings, which are widely separated. They're far apart. But look at my serosal border here, which is maintaining its convexity. See, one horn may be in Aurangabad, one horn may be in Raichur today. But if the serosal lining is maintaining its integrity, I don't worry of the angle here. See, angle, you do not worry. If this is shown in your figure, then it is a septate uterus. I have shown the depth also, which is more than 1 centimeter. Okay, that is one of the entity which I wanted to show. Why am I trying to show this case? This case is a thin septa. This is defining a thin septa with normal regular borders. Don't worry of this. This is a RPOC. See, in this case, for example, when I do a hysteroscopy, this is what you see. In hysteroscopy, that is the RPOC there. This is a right uterine horn. You have the ostia. This is the RPOC. Okay, on the right uterine cavity. And then this is the septa. This is a thin septa, and this is the left uterine cavity. See, when you have defined your imaging properly, such thin septa, you need not do laparoscopy. Your office hysteroscopy is enough because we are doing off late. Such septa, we are just cutting it in office hysteroscopy, that is without anesthesia. What about the fertility issues? She already got conceived. She is having RPOs, maybe definitely the tubes are likely to be patent. So that is one of the entities which help us defining whatever imaging you are trying to do. The surgeon or the endoscopy surgeon is not interested in reading what blah, blah, blah and all. Put yourself in diagrams. Put always yourself in diagrams. That will be more picturesque for the endoscopy surgeon. Maybe whatever classification you may follow, it is left to you. But you have to put a diagram such that the endoscopy surgeon will come to know what kind of septate it is. You might put angles or even lateral wall indentations and all. It is left to you. But putting yourself in diagrams will help them better. So maybe I have completed with septa. If I can ask the participants today, what is the diagnosis in this case? So I know some of you would have definitely had a thought that this is a very simple case and I can think it is a unicornate uterus. The answer is yes. We don't do HSG in our unit. So only those who pay, like if they come for referral, we do HSG. Do you think when I've done the HSG for this case, shall I put on the report saying that it's unicornate? No. Answer is no, definitely no. Why? I will show you. The same case when I did a 3D, this is what I get. Why did I get this? See, the case which was showing, which was one horn of the uterus, my Leach-Wilkinson cannula had entered into one of the cavities and this was only imaging this part. Okay, so the other was not seen. Even if at all, I would have seen two cervixes at my vaginal examination while putting the speculum, then definitely I would have put Leach-Wilkinson cannula on both sides, thinking that it is didelphys. But what about the uterine counter? That could not have been solved by just doing a HSG. So I will try to show in 3D, it is not always, 3D is also a real-time imaging. I'll try to show in this image. See, just 3D by putting it a coronal image is not the answer. In this particular case, I was trying to understand what made me to go into the right horn. So in this case, you are trying to see the septa is beginning from the cervical canal, but still the external os is here. I will try to show that better in the lower part of the imaging in this picture. Try to see here. This is on the left cervical lining. This is the right. Here is the external os. This is the cervical canal. This is one endometrial cavity which is leading to, this is another endometrial cavity. The septa is actually beginning from just from the cervical canal above the external os, above the external os. So my Leach-Wilkinson cannula had entered here. So while I was doing my HSG, I could see only one ostia. I can show that in hysteroscopy as well. This was the case with single external os. When we entered with hysteroscope, we directly entered into the right side of the cervical canal. So we came back, we had to stop there. Okay, we had to stop there to define my 3D imaging. So we came back slowly after adjustments of the focus. This is these are cervical crypts. So this was that, and just lateral to that, when we went, this is what we are seeing. This you are trying to see another cavity in cervical canal. So this was the cervical septa, which was dividing, which was leading to onto the left side here, and that onto the right side there. So this is how a 3D imaging has to be. 3D imaging is just not looking at the uterus in entirety as a whole. You may have to play your probes or your real-time imaging with 3D at the lower end also. For example, how this case differs from that case. Look here, this is also a complete septate uterus, but what about the cervixes? The cervixes are definitely two. They are definitely two. The 3D imaging itself is telling that there are two cervixes. So sometimes you may have to go lower down and do your 3D at the lower part and get those. I'm getting these two beautiful cervical canals. They are widely separate, as if you're seeing two widely separated cervix. They are bifid cervix. This is a bifid cervix. The previous case was a septate cervix. So you can also use the vaginal view 3D so that you can define this bifid cervix. So you can have a thick brand. Why is that important? Why is that important is because there are two schools of thought. You may not have to cut this part of the cervical septa for unification. Most of them only cut at the corpus part. This is what I'm trying to show. If this case would have come for my HSG, definitely I would have seen this in my speculum examination. There are two cervices. I would have put my Leach-Wilkinson cannula on either side. So, if I ask somebody to answer this after that case, never. Don't accept an HSG report saying that this is an anomalous uterus, saying that whether it is a bicornate or unicornate, this is how it is. You should not accept, and don't give your reporting only based on HSG. So in this case, I'm trying to place my probe in the anterophonics. I went towards the right side of the patient. This is what I'm trying to see, a good uterine cavity, uterine cavity. And when I saw the right ovary, when I went towards the left side, I was not able to locate the left ovary. I had to move towards the left of the patient, and this is what I saw. You could see two well-defined uterine cavities or two well-defined uterine bodies there. And this is what it is, a very simple case. So this is when I went to transfers. Look here, I had to reduce my depth to get them in entirety in my focus of vision and a field of vision. So you are able to see two well-defined uterine cavities. They are widely separated, and you have this dimple there, wide dimple, and you have this echogenicity, which is differing from your myometrial echoes. This is the peritoneal reflection that you have. So what I'm trying to show you is that it's a case of bicornuate uterus, or you can call it as didelphys. Whatever terminologies you want to use is left to you. I can call this as bicorporeal, bicolus, because I even lower down, I saw there were two cervixes. It was a well-defined two uterine cavities. So let me tell you, bicornuate uteruses are more common on the papers of the diagnosis. They are very, very rare. In 1 year or so, we will not cross even 2 digits of so many, but in a week or so, I will see a lot of maybe 2 or 3 septate uterus or 3 to 4 septate uterus, but bicornuate is not an easy. See, this is how a bicornuate uterus looks. Bicorporeal, bicolus. You have two well-defined cervices. They are separate apart. This is a peritoneal reflection inside, on the outside of the uterine counter. So you can look here. Look here, when I did the lower part of the cervix, I'm able to see two well-defined bifid cervix with a thick, broad septa. Why is it I'm trying to show you this again and again? See, a radiologist investigation imaging will not complete when you see two bifid cervix. When you have a thick septa like this, it is incomplete imaging. Maybe you have to go down and do your perspicuum examination and look for the longitudinal vaginal septa. The same case, I got a longitudinal vaginal septa, didelphys uterus with a longitudinal one. Usually they go with hand in hand. Unless, why am I trying to tell you this is because if these are patent, okay, if these both are patent, definitely they were patent. So you will try to place your probe in one vaginal cavity. So definitely the other will going to get collapsed. So you are not able to image this longitudinal septa. When you see two bifid cervix, it is a must that you have to do a PV examination also to look whether there is a longitudinal septa. Unless and until if you have something like an obstructed vaginal septa like Ovira syndrome and all, which I don't have the case today. So that case, they would have presented well in younger age, definitely would have gone for TAs in such cases and would have defined that. So looking out for a longitudinal septa also helps the surgeon to tell that it is what it is. So this case was a uterus didelphys, what you want to call by American Fertility Society, or I call it as bicornuate bicolus uterus. What is the treatment for such case? Just look for the fallopian tubes patency and come out. There is no role of unification surgery in these days. Okay, what about this case? This case, the same. We are seeing two well bifid horns. They are getting separated. The peritoneal reflection is seen in between. There is indentation there, but the cervical canal was appearing one. When I did 3D, this is what it is. Bicornuate, or you can call it bicorporeal unicolus uterus. You have a single cervix here. So this is how a 3D will help define the such cases. I want to pick up this. So what about this case? You are seeing a indentation on the myometrial fundal counter here. But is this indentation covering in its entirety to separate these horns? No. Now there is a criteria. For example, if there is a criteria, if I draw a line across this, and if this indentation depth, if I measure, if it is more than 1 centimeter, then I have to take it as bicorporeal entity. But still, you see there is some separation in between these two horns. This is a septate entity. So this is a mixed variety of having a bicorporeal septate entity. So this is the only image I have taken from the net. Rest all are mine. Where here you can definitely see there is well indentation of this. There is a very good indentation of the fundal encounter, whereas you have a septate part here. Why am I trying to show this to the surgeon is that if you put it in diagram telling that he should not overshoot, you can definitely widen this cavity to some extent, but definitely you should be aware that you cannot overshoot my hysteroscope scissors to go ahead. So this is how your 3D imaging will help. This case, a widely bifid endometrial linings, but the depth is less than 1 centimeter. This was, I showed it in my third image there. So this is a case of, it's not bicorporeal, it is septate uterus, though it is having a fundal indentation. So tomorrow when you start doing your scans, especially on the transverse view, and you start trying to trace your endocervical linings, endometrial linings, and if you find these bifurcations, you will go for 3D definitely. And once you get that, you get a imaging like this. So now some of you would have got in your mind that this is likely a normal. Yes, definitely. Some of you would have got in your mind that it is a arcuate uterus. Let me tell you, the word now arcuate is now normal. There is nothing called as arcuate uterus. So what about this case? So this case, when I call it as a normal uterus or a septate uterus, for that, we need to go for quantification. So in 3D imaging, if I try to put this imaging of the 3 important classifications, we all are aware of the X-ray, that the European people, we are all aware of the ASRM. These are the AFS people, okay? These were the people who gave the first classification, saying them as septate, unicornate, bicornate. The words were given by them, the didelphys. X-ray people tried to separate the corpus, the cervix, and the vagina separate. Only septate, the word they have taken. Rest all they kept it as bicorporeal, dysmorphic, and all, hemiuterus and all. I want to bring in a newer classification here, that is Q. This is a better classification for, if you look for a septate uterus and T-shaped uterus. They are the first people to quantify this T-shaped uterus, and septate uterus, they have better classification for that. What is that I'm trying to show? Whatever classifications you follow, they are trying to show, if look here, this is the fundal serosal lining. This is going to be your wall thickness. This is going to be your indentation depth. That indentation depth runs from the midline, that is, imagine the line that is joining between the 2 corners. This depth is the indentation depth. This is going to be a wall thickness. What these people are telling, if suppose if this is wall is 1 centimeter, and if the indentation depth is, even if it is 6 mm, more than 50% of that, then it is a septate uterus. What about X-ray? What about ASRM? ASRM now has got updated in 2021. They have made some correction after learning their mistakes, but still they have kept it as 1 centimeter now. So, and they have kept the angle as 90 degrees. So I have told you in my previous imaging that even if they are wide apart, don't go with the angles. So that is why Cume is a better criteria, where they were the first people to as 1 centimeter, and also Cume brought about the indentation to wall thickness ratio. They also included as the what the X-ray people, and they also told the preferred criterion is reliable of the 3 is the indentation to wall thickness. What they are telling is, wall thickness is suppose 1 centimeter, the indentation depth has to be 11 mm. Then only you can call it as a septate uterus. What about the angle? The angle, they have definitely increased it to 140. And what about the depth? They have kept it as, you can follow any of this. So it all depends on what classifications you want to follow, but you need to define your imaging such that whether am I looking into a septate uterus or not. Whatever classification you are following, try to put it on papers. This is your ASRM, the new paper that is in 2021. They have come up. Now they are calling nothing like arcuate. Arcuate is no more. Arcuate is now normal. Arcuate is not associated with any fertility issues. You keep it as normal. So this case I showed, yes, when I measured it is an arcuate, definitely it is an arcuate uterus. So I'm not going to confuse you people with putting up these charts and all of X-ray and ASRM. I like X-ray because they try to separate them different, but X-ray, if you follow, you are likely to overdiagnose septate uterus. I do leave it to my endoscopy, the endoscopy surgeon, to they have their own methods. So you have the uterine anomaly separate, you have the cervical anomaly separate, you have the vaginal anomaly separate. And what is the most important part? They give a box here, and it is a must that you have to draw a diagram, whatever uterus you have seen, and that is how it is. So dysmorphic uterus, they are well defined. That is why I like X-ray. Other ASRM is still not updated with the dysmorphic, especially the T-shaped uterus. So ASRM is easily downloadable. You can see they have included even the rarer Mullerian anomalies. Why am I not reading all this? Because once you have done your imaging, you can just open your phone and just see where is my anomalous uterus fitting, and just you can name that. Now they are also come up with the combined entity of bicornuate septate entity. They have used Robert's uterus in this classification. So it's not practical to remember all these things. What we need to do is how good we are in our systemic scans and how good we are in able to define those things. For example, in this case, when I was trying to do my sagittal sweep, my endometrial lining was only hitting one corner. Whereas when I came back to the middle and to the other side, I immediately lost the endometrial lining. So when I went towards the what is that? That is a transverse view. When I went to the transverse view, this endometrial lining was as a tubular fashion was leading towards one side of the patient. So that is what I want to tell you. I was trying to maneuver a lot in the vagina to get this in Sag as well as in the transverse view. So, and also one of the ovary was very close to this uterine horn towards which the endometrial lining was moving. So what is this case? This case, you will get an idea that something wrong in this case. So when you have an uterine endometrial lining moving towards one side, and if you are trying to figure it out, a lot of maneuverability, yes, you are dealing with a case of unicornate uterus. Why am I what is this lesion? She's a case of previous LSCS. Fertility issues, even if you have a unicornate uterus with good uterine cavity volume, it is not an issue for unicornate. But what is important in unicornate is that maybe you have to go for transabdominal sonography to look for any rudimentary hormone, whether they are cavitatory lesion having an active endometrium, or whether it is communicating or non-communicating. At the same time, we gynecologists often miss to look into the renal pathologies on the mother. So you have to always check for the abdominally, check for the mothers, the ladies, kidneys also, which the radiologists you often do, but we don't do. So we have to learn from this. That is, you may have to go for transabdominal sonography in such cases, and you can render images after that. So after doing that, I would try to play this clip. I want to look here because my systemic transvaginal sonography, when I am doing my sagittal views, was everything normal. When I went back to my transverse view, was appearing normal to me. So this lady presents with history of recurrent pregnancy loss in the first trimester itself. So what is that? What is that is making me, when I am doing my 2D systemic scan, I don't find anything there in the endometrial lining also. So when do I need to do a 3D for such cases when everything looks normal? Yes, definitely, because this is what I'm getting for the same case. This is a dysmorphic uterus. This is a case of T-shaped uterus. Now you have to quantify this based on the calculations that I will be showing here. Just I want to skip this for the time being. So how a T-shaped uterus looks, where you don't find the cornua in the first go, and you don't find the cornua in hysteroscope in the first go. You may be, when you have quantified better, saying that you have a good lateral wall thickness, you have to widen the cavity based on the energy sources, whatever the surgeon wants to use. Maybe it is the scissors, or maybe it is the whatever energy sources. So the same, another case where I was looking, everything was looking normal. Everything was looking normal in my 2D. But when I did a 3D for such a case, this is what I got. Deep-seated cornua, and look at the endometrial lining. This is definitely a tubular cavity. This is a tubular cavity, and this fulfills the criteria of T-shaped. I am trying to show the measurements, which I will skip the part of this, where I will put up the screen. See, Q are the first people who have shown about quantification of T-shaped uterus. So what they are trying to tell you is the cornal endomyometrial junction here at the interface. If this angle is less than 130 degree, and if this angle at the cornu, if it is less than 40 degree, this is the 40 degree, this is 130. Okay, and if you have an imaginary line taken from one of the cornu, from one, sorry. So one of the cornu to the isthmic, you don't have to include the cervix here. If this lateral wall indentation is showing more than 7 mm, then definitely a surgeon can give enough cuts. That is, we are telling that it is this patient, this uterus is having good lateral wall thickness. Then you can cut enough to widen the cavity. So this is how it helps. This is how it helps. So we, this is my boss, that is Dr. Jayaprakash Patil sir. We do these corrections under anesthesia. Definitely, it depends on the preference of the surgeon. So once you have done your correction, you will be able to appreciate the deep-seated ostia are appearing in your field of vision, and also the cavity appears widened. So this is how a T-shaped uterus will help us in some of the cases of your infertility. So what about this case? This case, definitely you have very good obtuse angles and all. This is actually the case which we operated on that. This is the T-shaped uterus which got operated, and this is now she has conceived. She has moved more than 22 weeks of gestation. She is doing good. One more important thing I want to share. Any Mullerian anomalies, it is a must that we have to look for cervical incompetency in the pregnancy when they have conceived. Keep monitoring, especially T-shaped uterus are known for cervical incompetence. This patient, she has underwent a Shirodka stitch as well, and she's doing good. So I don't need to explain this because it's very obvious that if look at this dysmorphic uterus, definitely it's having a poor pregnancy outcome, and look at the shape of the uterus. It is a T-shaped uterus. So you have now something two more entities. When I got the image, I thought it is a unicornate uterus, but my hysteroscopy showed there are two ostia. They are well defined, but in unicornate you will see only one ostia. So this is again a tubular shaped cavity. Here also I thought it was subseptate uterus, but no, look at the tubular cavity that you have, though the very deep seated ostia. So now what you have, a subtype of T-shaped uterus, that is I-shaped and Y-shaped. Read about these T-shaped uterus. They are easily available in by a person called Alonso, is a person who has done a lot of research on this. You have these videos. So one more important entity here I want to share. Any uterus, if it is less than 6.5 by the international guidelines, they say take it as hypoplastic uterus. I cannot generalize this for my Indian women. I have seen many with 6 centimeters with 3 children. Maybe I have to reduce it less than 6 or 5.5 if they are infertile. So in that case also you have something called as infantile uterus, or you can have a hypoplastic uterus. If the ratio of corpus to cervix is 2:1, then it is, and if this centimeter is less than 6 centimeter, I keep it as hypoplastic, whereas in this case, I keep it as infantile. Day before I got a call saying that I have a T-shaped uterus been diagnosed. Can I send the patient for correction? The first thing I asked after some discussion, I asked, what is the length of the uterus? They told the length of the uterus in SAG is just 5.5. See, when you have a uterus like an infantile, even if you do a 3D in such cases, you have a T-shaped morphology. In such cases, you are not supposed to do metroplasty. So that is how your imaging does help the surgeon to tell that you are dealing with an infantile, not a T-shaped uterus. So you can put her on cyclical estrogen and progesterone, then help that. So here it is an infantile uterus, a small uterine blood with this uterine bud. The corpus to cervix ratio standing at 1:1. A normal looking uterus, but when I measured the total length, it is falling just around, just below 5.5. But the corpus is two part, and this is one part. This is 2:1. You can call it this as hypoplastic. This you can call it as infantile. So this case, I just want to rush. Okay, when my 3D imaging in that case, in this case, is trying to define me, there is a broad-based fundus here with small dimple, whereas one endometrial lining is towards the cervical os, that is, it is communicating with the external os. Whereas we are able to see something which is there in between a septa over there, and you find some same lining as that of the endometrial lining in this cavity. So when we did hysteroscopy, we were just looking into one ostia. We were able to deal only this part. We are not able to see this part because there was a septa. We thought it was unicornate uterus. When we went laparoscope and confirmed, it was a broad-based, normal-looking counter of the uterus. And what is that case I'm trying to define in my 3D? This is a case of non-communicating septate uterus. Non-communicating septate uterus to the external os. This is a case of Robert's uterus. So Roberts can have a functional endometrium or an atretic endometrium. This case which I got was an atretic endometrium. I put it in diagrams. So this is a septa there. We thought it was it is definitely a broad and broad-based uterus. This is a Robert's uterus, whereas you have an endometrial lining which is atretic. You can have a role of cutting the septa and widening this cavity. Suppose if the endometrium on this side was functional, they would have presented very early in the age group with severe dysmenorrhea. That is when you would have got it, the diagnosis. You have to cut open this part and lay open the space such that it's going to communicate to the external os. So Robert's uterus is a rare entity, but still only a 3D will help us define such cases. 3D is going to help us, especially in a T-shaped uterus. We can quantify and help the surgeon that whether I can cut it laterally, and also in Robert's uterus. And one more case I want to show, that is, sir, can I take for some more time, or can I? Because this case, so this case, I just want to
you can
share.
go ahead.
Thank you. This case I want to show where a young lady who was 19 years of age presented with history of severe and progressive dysmenorrhea. I did a transabdominal sonography when I was able to see a circumscribed hypoechoic lesion on one side, that is on the right lateral side near to the fundus, whereas near to the fundus, and it was having low internal echoes in that lesion, and the rest of the myometrium was looking absolutely normal. And when I went to the transverse plane, I was able to see the endometrial lining was getting stretched across to both the cornu. I mean to say the endometrial cavity was appearing absolutely normal, and this lesion was well within the myometrial mantle, and it was close near to the fundus to one side. So this case, when we put it in diagrams, we got this when in 3D, a normal uterine triangular cavity, endometrial lining, a cavitated lesion. So when I put it in diagrams, this is what we are getting. So we put it like this is a cavitated lesion with hemosiderin-like pigment inside. So this case is what you are now looking at, that is ACUM, accessory cavitatory uterine malformation. 3D will help define that to locate the lesion. And why is that important is that we don't want to give unnecessary cuts on the uterus. We just have to specifically go at that particular lesion and bring out this lesion, which proved out to be accessory cavitatory uterine malformation. We had one more case. 3D is not always coronal. This is what I want to show. This is from the, if I am the uterus, this imaging is from my head from above. So the endometrial lining was its regularity at its fundus, where you have a cavitated lesion towards one side. This was actually defining as a acum. So in acum, in coronal plane also, you will get a normal looking endometrial lining, whereas towards the one side of the round ligaments, just below that, you have the specific lesion. Most of us confuse that with the myoma or an adenomyoma, that we have to be specific. So this is in short about understanding Mullerian anomalies that I wanted to discuss. Maybe, yes, we have to be very thorough and systemic in our transvaginal sonography. In our 2D itself, we'll be able to get a lot of hints, and 3D will help define them better. So yes, quantification of a septate or a T-shaped uterus sometimes definitely help the surgeon, for the endoscopy surgeon, to tackle them better. This is I have a short in discussion for understanding 2D and 3D for Mullerian anomalies.
Yeah, thank you, Doctor. It was really a wonderful imaging, and it's a beautiful what images you have shown in 3D. They're absolutely a wonderful guide for a hysteroscopist to go ahead and I have been enlightened with the cum classification that is new to me, and it was really a good guide to know the musculature of the uterus. Thank you so much for enlightening with this super presentation, Dr. Raju. Thank you so much.
Thank you so much,
Thank
ma'am.
you.
Thank you so much, ma'am. Thank you, ma'am.
Thank you, ma'am. Excellent presentation. It was a treat to eyes. Very nice videos, sir. Thank you so much.
Thank you, ma'am.
Thank you, sir. Moving toward our second session, ultrasound in infertility. I would like to invite second chairperson of today's session, that is Dr. B.S. Jodha, sir. He is a Master of Surgery, Senior Professor, Dr. S.N. Medical College, Jodhpur, Rajasthan. He has done diploma in the gynec endoscopic surgery, France, trained in ultrasonography, ART, fetal medicine. He is a secretary of JOGOS, Marwar Achievers Award 2015, postgraduate and undergraduate examiner in various universities, India, paper setter in university exams and review editors in the journal, and national master trainer of various government sponsored program, various publication in the national and international journal. Welcome, sir.
Thank you. Thank you very much.
Yes, sir. I would like you to invite Dr. Aarti Tolani, madam, for second session.
So I invite Dr. Aarti Deendayal Tolani, ma'am. She is currently Director, Fertility Spaces and Scientific in charge of Mamta Fertility Hospital, Associate Editor of Minerva Gynecologica, and Secretary Telangana ISAR 2012, faculty at the Healy School of Reproductive Medicine, Germany, and team member of Project Pelvis, a member secretary Institutional Ethics Committee of Infertility Institute Research Center, Hyderabad, with various awards and publication in her name. Kindly proceed, Dr. Aarti Deendayal, for your deliberation on this.
Very good evening, everyone. Thank you so much, sir, for that kind introduction. Yeah. And before starting off my session, I'll just share my screen. Just give me 1 minute. Can you see my screen, sir?
Yeah.
Right. So before starting my session on ultrasound in infertility, I want to take this opportunity to thank the Aurangabad Fetal Medicine Committee, Dr. Sujit in particular, for inviting me. It's really a privilege and honor to be here. Respected chief guest, it's such an honor to have you over here on this platform. And thank you so much, guests of honor and the office bearers, the MOC, everyone present here. Real honor to be here. And ultrasound is a topic very, very close to my heart. And today, what I'm going to take you through is a pictorial assay of ultrasound in infertility. I don't think I will be able to do justice to what ultrasound can offer in fertility practice, but then I'm going to take you through, the foundation. I want to make it as practical as possible. This session is dedicated to all of those colleagues of ours who have not yet started doing ultrasound or who are doing ultrasound and taking baby steps This, of course, is dedicated to them. So with this as the background, let's start with why is it? Yeah. Can I continue?
Yes, ma'am.
Yes, yes.
Right. So with this as the background, let's start with why is it that ultrasound is so important in fertility practice? We know that ultrasound gives us insights for accurate diagnosis and management. We can share observations with our patients. Ultrasound helps us bring home a baby and achieve success. But then, is this the meaning of bringing home a baby? Is this success? Is this success? Are we responsible? Or is this success? Are we responsible for this? So keeping this in mind that ultrasound helps in diagnosis, but then ultrasound also helps us in minimizing complications and iatrogenic issues like a multiple pregnancy. We should keep this in mind that we should use ultrasound to sort of minimize the risks and maximize the beneficial effects of treatment. So this profound realization dawned on me very early on in my career that infertility is the only specialty in medicine where there are 200 diseases, only 5 types of drugs, and one real diagnostic tool, and that is ultrasound. So I'm going to take you through the steps from a follicle to a fetus, the journey monitored by ultrasound. I'm going to take you through how we do an initial diagnostic scan, how to do a pre-treatment assessment, how we use ultrasound to calculate the dose of stimulation, monitoring of follicular and endometrial response, triggering ovulation, and how ultrasound is used in interventions like an oocyte pickup and, of course, an embryo transfer. So as I just mentioned, the potential of ultrasound in infertility is so vast, so wide. I won't be able to do justice and cover all the nuances of using ultrasound in each aspects of this treatment, but then I'm going to focus on the foundation of how to do a basic, thorough initial diagnostic scan. Can you see my image, Dr. Suji?
Yes, ma'am. Yes, ma'am.
Right. Okay. So we must understand that we have a toolbox in ultrasound. We have to use the transabdominal and transvaginal 2D and 3D scan. When we are assessing the pelvis and abdomen, we should know what are the situations where a transabdominal scores over a transvaginal. When there are large dermoids, when there are masses extending into the upper abdomen, in cases where there are small ectopics, cervical fibroids, or where the endometrium is in a mid position, this is where a transabdominal scan scores over a transvaginal scan. We should use Doppler to our advantage. Understand that there are 3 types of Dopplers: color, power, and HD flow. And when you're doing a pelvic ultrasound, always put your PRF at 0.6. Use the pulsed wave Doppler for quantitatively assessing and calculating velocities and indices. And of course, 3D Doppler should be used to get a spatial orientation of blood flow. Now, why should you Doppler? Because you want to know whether the flow is present or absent, what is the abundance of flow, what is the flow direction, morphology. All this adds information and reconfirms our findings on 2D and, of course, improves accuracy of diagnosis. So this is the toolbox we use. We use transabdominal. We do, of course, a abdominal transvaginal scan, do a thorough 3D scan, and always use your Doppler. Now coming to
you had a fibroid, yeah.
The diagnostic scan, how we do it. By the end of the talk, I want each of you all to be able to describe the steps involved in performing a complete evaluation of the female pelvis. how to do a baseline scan and why, and know the outline of how ultrasound is a powerful tool used at every step of management. Now, you must understand the concept of compartments when you are doing a vaginal scan. That is, when you are doing a vaginal scan, we look at the anterior, middle, lateral, and the posterior compartment. And I'm going to take you through how we are going to look at the compartments. Let's start with the anterior compartment. When we are looking at the anterior compartment, we start with a semi-filled bladder, looking at the semi-filled bladder, the bladder wall, if there are any thickenings, if there are some sort of calculi or irregularities. Two, you look at the sliding sign. You look at how the UV4 slides away from the uterus. If it easily slides away, it indicates that there are no adhesions. And when it doesn't slide away, this is an indicator that there may be bladder wall adhesions. Always make it a habit to look at the ureters, because ureters are typical long tubular hypoechoic structures which demonstrate peristalsis. You look at the ureteric jets within the bladder, because again, this tells us about good kidney function. And when you don't see it, you may suspect some sort of a obstruction on the ureter, which can happen in adhesions or endometriosis. Always look at the kidney for the presence, absence, or an abnormal position of the kidney. Like if you're seeing a pelvic kidney, also look for any hydronephrosis in the kidney. So just to recap of the anterior compartment, when you're looking at the anterior compartment, look at the bladder wall thickness and irregularities, look at UV fold, look for ureteric jets, and look at the kidney placement. Now coming to the middle compartment.
No, not really. Like you passed your
Possible to mute the other.
No.
The.
Did you get your old report? You tell me roughly. I'll tell you whether.
Kindly mute.
Okay.
Just give me 1 minute. I'll just get some water.
10 minutes, Sharma. I'll finish off this. Yeah.
Somebody's on unmute. Kindly mute it.
Can I continue, Dr. Sujit?
Yes.
Yeah,
Can I continue?
Delegates are more interested in listening to you rather than other delegates, ma'am. Please unmute yourself, dear friends.
Yeah. So now we're talking about the middle compartment. When we're looking at the middle compartment, we look at the uterus, you take some measurements, and of course, evaluate the uterus in toto for any abnormalities. Make it a habit to look at the angle of version, angle of flexion. Now, if it is an anteverted retroflexed uterus, you know that there are some sort of adhesions in the pouch of Douglas, which is associated with endometriosis. Always make this examination a dynamic, real-time ultrasound examination, and place your left hand on the abdomen and, bellot the uterus so that you can see whether the bowel is actually moving all over the uterus or not. Because if you do not see this free bowel movements, it's a sign of some sort of adhesions. Look at the sagittal section, make your measurements in the sagittal section, look at your endometrium, look at the thickness, ecotexture in this plane. Dr. Raju beautifully demonstrated the most important plane when you're doing a 2D scan of the uterus is the transverse plane, because this is where you can actually pick up uterine anomalies. He gave us some fascinating 3D ultrasound pictures as well. Now, once you look at the version, flexion, take your measurements, make it a habit to look, of course, at the myometrium for pathologies, look for abnormal ecotexture, fibroids, adenomyosis, look at the cavity, look for the presence of intracavitary lesions, any breaks in the continuity of the endometrial echo, submucous myomas, polyps. So you look at the uterus in toto. Again, use a Doppler. If it's a baseline scan, put on your Doppler, look for the blood flow, because if you are seeing too much of a blood flow, it's a sign of maybe chronic endometritis or high progesterone levels, high estrogen levels. Put on your Doppler when you see a mass within the myometrium to differentiate it between a submucous myoma and a polyp. Now, put on your Doppler when you see a fibroid and adenomyosis. A fibroid will have circumferential vascularity. Adenomyosis will have translesional vascularity. Again, put on your Doppler when you're assessing the endometrium just before your embryo transfer. We have the Applebaum scoring, which I'll talk to you about, towards the end of this session, where based on the vascularity, you can actually judge how successful that particular cycle can be. When you see a mass in an adnexal mass, again, put on your Doppler if you want to know where exactly this, mass is arising from. So if you can see over here, we put on the Doppler for this mass and we saw this is the claw sign, that is a pedunculated subserous myoma. Again, use your 3D Doppler so that you have a spatial orientation of what exactly is the pathology. Look at the junctional zone. Is the junctional zone normal, well-defined, or is it irregular? Are there breaks in the junctional zone? Are there irregularities in the junctional zone? The junctional zone is best assessed in the coronal plane, because in the coronal plane, you can actually make out endometrial buds, irregularities, a sign of early adenomyosis. Again, when you're looking at the middle compartment, look at the cervix. Dr. Raju again beautifully demonstrated how we must focus on looking at the cervix, especially in case of Mullerian abnormalities. Now, this is a very beautiful case who came to us with a history of failed embryo transfer, difficult failed embryo transfer in the previous cycle. And all we did is just do a simple 2D, 3D scan. We saw a large Nabothian cyst. All we did is do a hysteroscopy, puncture the cyst, and then in the subsequent cycle, she was pregnant. Here, this is a patient who came with a postcoital bleed, and we saw a large cervical polyp, and we followed the polyp upwards, and the pedicle was coming from the endometrial cavity. So this, polyp should not be just pulled in the OP, because this can, result in a torrential bleed. So it's important when you look at a polyp, follow it as to where is the pedicle coming from. This, I'm just demonstrating various examples of how we must look at each aspect of the lateral compartment. Now, again, this is a patient where the cervix looked apparently normal on per-speculum examination, but you can see here, the cervix on ultrasound looked very bulky, and on Doppler looked very vascular. We biopsied the cervix and it turned out to be CA cervix. So after this, always also end your middle compartment examination by looking at the vagina. Look for any vaginal nodules, because again, any vaginal irregularities, hypoechoic areas, thick, tender areas signify that maybe there is also endometriotic deposits on the vagina. So just to recap into the middle compartment, look at the cervix, look at the myometrium in toto, look at the endometrial cavity, look at the junctional zone. Do not forget to look at the vaginal wall. Take your measurements, look at the version and flexion. As I told you, an indicator of a possible endometriosis is a sickle-shaped or a C-shaped uterus. And of course, if there are pathologies, use your Doppler so that you can differentiate various pathologies. So this is about the middle compartment. Now coming to the lateral compartment. Now, when you're looking at the lateral compartment, of course, you are looking at the ovary. You're looking, again, you have to make the examination of the ovary dynamic, interactive, look at the size, volume, antral follicle count, which I'm going to take you through, but also look at the mobility, elasticity, and tenderness in and around near the ovary. Now, when you are performing an antral follicle count, place your ovary in the center of the screen. It should occupy 50% of the screen along the largest axis. Look at the longitudinal and transverse plane. Put your harmonics button on so that the follicles are better defined. Any color can be used as long as there is minimum noise or clutter. When you're doing a 2D scan, use the eyeballing technique, count all the follicles between 2 to 10 mm in size, measure when in doubt in 2 planes. Always remember, real-time imaging of the antral follicle count is much better than offline, especially to delineate between intrafollicular and paraovarian structures. Based on the follicle count, you can go ahead and classify whether the patient is a poor responder, a normoresponder, or a hyper-responder. And based on this information, then, of course, you can make your calculations of dose when you're planning treatment. Now, you prefer to do an antral follicle count in the baseline, that is during the period, because in the presence of ovarian cysts, either in the middle of the cycle or towards the end of the cycle, we may not be actually able to get the right follicle count. And in ovaries which are displaced and present far away from the probe, again, sometimes you will not be able to make out the right antral follicle count. Look at the relationship of the ovary to the ovarian fossa and surrounding structures. Look for the presence of periovarian adhesions. Look for the presence of teomas or adhesions to the uterus. When you are seeing an ovarian cyst, again, look at whether it's a simple cyst, whether it's a hemorrhagic, physiological corpus luteal cyst, dermoid, or an endometrioma. Now, when you see the ovarian crescent sign, that is, you see the presence of follicles around the, abnormal cyst, you know that it is an ovarian mass. And when you see the mass separating out from the ovary on, movement in the vagina, you know you're dealing with a paraovarian cyst. That's called as the splitting sign. Now, when you see an endometrioma, again, look at whether it's a typical endometrioma with just a typical ground glass appearance. Is it atypical? What is the vascularity? Also do a pain mapping, that is, use your probe like your fingers in order to find out which structures are, painful. When you see kissing ovaries, also remember this is a sign of a very severe endometriosis. And most of these patients with kissing ovaries have associated moderate to severe endometriosis. Then, as I mentioned, when you make all your measurements, use all these measurements to make your calculations about what is the dose of drug you want to give when you are planning ovarian stimulation, whether it is for IUI or for IVF. And I'll talk to you a bit more in detail about it in the coming slides. Now, coming to where do we use Doppler when we are looking at the lateral compartment? We use Doppler when we want to plan your timing of your HCG. Again, I'll talk about it a little bit more detail in the further slides. Now, we use Doppler when we want to assess perifollicular vascularization, because we know that well-vascularized follicles have better quality oocytes and better pregnancy rates, whether it is in IUI or in IVF. Now, when you're looking at the lateral compartment, also you're looking at the tube. A normal tube cannot be seen, but if there is a periovarian fluid at the time of ovulation, you can see the fimbria. Also look for the presence of hydrosalpinx, because you know hydrosalpinx are incomplete retort-shaped structures with incomplete septa. Look for the presence of peritubal adhesions. So you can see over here the flapping sail sign, that is, these adhesions in the presence of fluid will undulate and flap and oscillate under pressure. So this is an indication that we are dealing with peritubal adhesions. And this is the laparoscopic correlation. So just a recap again of the lateral compartment. Believe me, it sounds like there is a lot to do, but when you do it over a period of time, it just becomes your second nature to look for all these things which I am mentioning. So when you're looking at the lateral compartment, you're looking at the ovary, or you're doing your measurements because you want to know what type of responder the patient is. You're looking at the mobility, you're looking at the relationship to the surrounding structures, you're looking for any abnormalities in the tube, presence of hydrosalpinx, you're looking for pathologies, cysts, and you're doing a pain mapping as well. So if you look into all these aspects of, when you're doing an ultrasound, you cannot miss any pathology. Now coming to the posterior compartment. Now, when you are looking at the posterior compartment, you are looking at the mobility of the bowels in the posterior compartment. So you can see over here, when again you're doing a dynamic examination, you're ballotting your left hand and you're looking at the sliding of bowels over the uterus. And you could see over here in this image how this bowel over here is adherent to the posterior surface of the uterus. Now, how do you trace the bowel with ultrasound? Though this requires practice over a period of time, we will get how to do it, but you must know that we can actually assess about 20 centimeters of bowel through the TVS, and we should know that the bowel has an external muscularis, which is hypoechoic. You have a hyperechoic submucosa, and you have again a hypoechoic mucosa. So when you are looking at the bowel, you're following the bowel and looking for any irregularities when you are sort of following the bowel. And when you see these irregularities, you know that you are dealing with possible bowel endometriosis, like you are seeing over here in this ultrasound video. So you can see over here, there are bowel adhesions, and you can see over here a typical bowel endometriosis. So how do endometriotic nodules look? They are hypoechoic, they have diffuse border, they are firm and tender when pushed, they are poorly vascularized. Now, also when you're looking at the posterior compartment, look at the uterosacrals, go to the cervix, and in the transverse section, look laterally, and you'll see if there is any tender area or there are any nodules, you know that you're dealing with uterosacral endometriosis as well. So as you can see, success is nothing more than just practicing a few simple disciplines every single day. So just for me to summarize what all you are looking, because if you get this, doing everything else is very easy. So the stepwise assessment is you look at the anterior compartment, the bladder wall, UV fold, ureteric jets, kidney placement. You look at the middle compartment, you look thoroughly at the cervix, the myometrium, the endometrium, the junctional zone, the vaginal wall, take your measurements, look at the anteversion flexion, look for pathologies. You look at the lateral compartment, look at the ovary, take your measurements, do your antral follicle count, look at the mobility and relationship to the surrounding structures. Doppler, if you are seeing any pathological cyst, do pain mapping, look for the presence of any hydrosalpinges or tubal adhesions. And when you're looking at the posterior compartment, you look at the mobility of the bowels in the posterior compartment, you trace your bowel, look for bowel endometriosis, and do not forget to look at the uterosacral. So this, my friends, is just a overview of what you should be looking at when you are doing a diagnostic ultrasound in your infertile or subfertile woman. Now, never ever forget to give, since you're doing such a thorough ultrasound, you never forget to give a detailed report. As Dr. Raju also mentioned, make it a habit. We will give all our measurements and all our findings, but one picture speaks more than 1,000 words, and that you should make it a habit to draw what you are seeing, because this is what the patient understands, this is what her family understands, this is what the referring doctor also will relate to. So draw a line diagram, your impression of the type of pathology or possible differential diagnosis, suggest investigational tests or requirement for follow-up scans in your report, and discuss your findings with the referring doctor. When in doubt, you have wonderful seniors in, practicing in and around you, who you can just take a phone and ask for another opinion. Now, of course, this, the art of drawing your pictures, I have learned it from my mentor, Dr. Mamta, and I urge all of you all to also develop this habit of drawing whatever you see, and all it requires is just that passion and want to, draw all your findings, what you see on ultrasound on paper. And so, of course, because of this passion of me wanting to draw and show what I am seeing on ultrasound, I too make it a habit to draw my, diagrams on paper for my patient and the referring doctor. This is a very important take home. So now that we have covered the first step of doing a thorough diagnostic scan, quickly, Dr. Sujit, do I have another 10 minutes or so, and 10 to 15 minutes max, and I'll complete my presentation?
Yeah, sure, ma'am. No problem.
Okay. So now the second step is your baseline scan. Now, why are we doing a baseline scan? Because a baseline scan is a scan done for selection, preparation, and assessment of a patient before starting a stimulated treatment cycle. Why should we do a baseline scan? Because it tells us whether there is an adequate physiological state for stimulation in the ovaries. We are also excluding any pathology and evaluating the ovarian response by evaluating the ovarian reserve. Like I mentioned, when you're doing an antral follicle count, it's always better to do the antral follicle count during the first 5 days of the cycle. With this information that we are going to gather on a baseline scan, we are going to be identifying, that is in the 4 steps of management for ovulation induction. Step 1 is identifying the patient background and ovulatory profile, and step 2 is designing a proper ovulation induction protocol, and this is where a baseline scan helps. Why do we want to do it? Because we want to prevent poor response. We want to prevent hyperresponse. We want to reduce side effects, improve pregnancy rates, and reduce the physical, psychological, and financial burden on the patient. Again, is there a systemic rational approach? My basic checklist, which I follow, like I've given you a checklist for a diagnostic, ultrasound, the checklist for a baseline scan is, once more, I look at all the compartments quickly and exclude any pathology. And then we do a baseline scan of the ovaries, uterus, and look at the adnexa. When you're looking at the endometrium, you're looking at the endometrial thickness. Why is endometrial thickness important? Because you want a flat endometrium with less vascularity to start, your ovarian stimulation. Because if you are seeing high vascularity in the endometrium, this is not a very good sign. And as I mentioned earlier, this is a sign of chronic endometritis or higher estrogen progesterone levels. Endometrial thickness is very important before you start stimulation. We prefer a flat endometrial thickness less than 5 mm. Thick endometrium, again, what does it mean? It may mean that maybe the endometrium is not completely shed. It may mean that there may be also endometrial polyp. And another thing you must make it a habit to do when you see a thick endometrium is always do a pregnancy test. I've seen multiple times patients treated elsewhere with a thick endometrium, ovulation induction drugs are started, and doing a pregnancy test was missed in the first go, and these patients landed up with a ruptured ectopic pregnancy. So when you see a thick endometrium, take home this message that you should do a urine pregnancy test. When in doubt, do also a beta HCG. When you're doing a baseline, as I mentioned, again, take this opportunity to rule out any uterine pathology. So that is as simple as it goes. Look for a thin endometrium, put on the vascularity, put on your Doppler. And if the endometrium is thin, you know that you're all set to go, provided everything is okay in the ovaries. Now, when you're looking at the ovaries, again, what are you going to do? What is your checklist? You're going to exclude ovarian pathology. You're going to look at the follicular count, FNPO, that is the follicular count per ovary. You're going to look at the volume, because this is going to give us information whether the patient is a poor responder, normo-responder, or a hyper-responder. So what you're going to do on your baseline scan, do the follicle count, look at the ovarian volume, look at the accessibility of the ovary. Now, this is a very interesting case we saw, and I hope you learn from it too. This patient came to us way back. You can see the date here in 2004. This is a story my mother always tells me, and so it's ingrained inside me. So this patient, you see this ovary, it looks like she's a poor responder. Hardly there is a follicle count of 1. Left ovary, there is nothing at all. You couldn't visualize it. The patient doesn't give any surgical history. And this patient, because she appeared to be a poor responder, was stimulated with a very high dose of HMG. And after the whole cycle and the IUI was done, later on, that is after the IUI was done, around day 8 or day 9 after the IUI, she came back with typical signs of hyperstimulation and fluid in her abdomen, but this ovary just had one corpus luteal cyst, and we could not understand why this was happening. Then later on, the hyperstimulation was managed, the patient settled, she got a period, and then a laparoscope was put inside, and what was seen was this ovary was absent. The left ovary was absent, but then where was this left ovary? It was present below the omentum, and it looked like a normal, quite a large ovary with which looked maybe which was maybe polycystic. So the story goes that this patient had an episode of severe pain when she was a child. So we are assuming, and we came to the conclusion that maybe she had a spontaneous torsion and this ovary went and got attached below the omentum. That is why we could not see it. And that was the ovary which hyperstimulated in that particular cycle. So this is just a story for you that when you don't see the ovary, you don't have a surgical history, still search for the opposite ovary. Look at the relationship to the surrounding structures in your baseline scan once more, and look for the presence of ovarian cysts. And if it is a vascular ovarian cyst, it is better that you do not start ovulation induction medication, and the treatment should be delayed to the subsequent cycles. And importance of screening, again, tubal pathology, because if you are having an associated hydrosalpinx and it is communicating with your endometrial cavity, it's not going to give you great results, whether it is an IUI or whether you're going to be doing a transfer after your IVF cycle. So for a baseline scan, look at the ovary, AFC, volume, blood flow, look at the stroma, look at the endometrial thickness, subendometrial blood flow, rule out pathologies, and then see if everything is okay to start stimulation or not. So that was the second aspect, most important foundational aspect of using ultrasound in your baseline scan. Now, how do you use ultrasound for dose calculation? Again, you need all ultrasound parameters like AFC, volume, stromal, RI, PSV, and based on these parameters, there are multiple nomograms available for calculating your dose to start stimulation, whether it is in IUI or IVF. Now, coming to monitoring in the follicular phase, my colleague is going to be talking about follicular monitoring after me, so I'm not going to dive into details, but just take you through some important points that when you are monitoring a cycle, you're looking at the follicular diameter, the growth, and the vascularity, along with the endometrial thickness and texture. Who does the ultrasound? Many a times I see we gynecologists depend on, radiologists to do the ultrasound. Please take home this message. Do the follicular monitoring yourself. The amount of information you will do, which you will get when you do your own follicular monitoring is humongous, and you can do so much of justice to the patient. So you measure the follicles. Most important is these little things you should look for when you are doing follicular monitoring. The first change after the LH surge is seen on ultrasound is the separation of the granulosa and theca, producing a crenated pattern of the follicle. Also, you see increased follicular blood flow. Also look for the presence of this hypoechogenic projection within the follicle, which is the cumulus. 20% of follicles will have a cumulus, and when you see a cumulus on ultrasound, this is a sign that maybe this follicle has a mature oocyte. Look at the endometrium, look at the texture, also know how the texture differs in the proliferative and the secretory phase, and know that there is going to be increased vascularity within the endometrium, and there is going to be a fall in the vascular indices after ovulation, which is essential for embryo implantation. I'm not going to go into the details of follicular monitoring because I'm sure our colleagues will give my colleague will give us insight about how to do a thorough follicular monitoring. Now, this is just one tip when you are, the most important step when you are planning your, trigger is not only looking at the follicular size, but also looking at the endometrial thickness before you give your trigger. This is a very beautiful paper which shows that there is no harm in waiting till the follicle is larger in size, especially when you are having, say, 18 mm follicle and say an endometrium which is just about 6.5 or less than 7 mm in thickness. So do not go by just by the follicular size or diameter, but also look at the endometrial thickness when you are planning trigger. Make it a habit to put on your Doppler, look at the perifollicular vascularity. If it is 50 to 75%, qualitatively, if you're assessing it, or quantitatively, this is a very beautiful paper of Dr. Sonal and Dr. Nagori, and we follow this in our hospital as well. When we see an RI of less than 0.5, PSV of 11, you know that this is the right time to trigger. And believe me, your friends, if you can use this one step of using Doppler before planning your trigger, your pregnancy rates will definitely increase at least by another 4 to 5%. And the outcome of the cycle can be also assessed by ultrasound, as I had mentioned. We can look at the vascularity and predict the oocyte quality. We can predict the risk of OHSS pre-stimulation and during stimulation as well. And you can predict just based on your ultrasound whether there is endocrine synchrony or dyssynchrony. Endocrine synchrony is when you are seeing just before ovulation a beautiful triple line endometrium, you're seeing plenty of cervical mucus, you're seeing beautiful mature follicles with or without cumulus with good vascularity. You know that there is endocrine synchrony. But when you see that the follicle is rupturing before time, when there is absence of corpus luteum, there is a dysynchronous endometrium, type 4 changes in the endometrium, or a thin endometrium, you know something is going wrong somewhere. Now, again, I'm not going to go into the nuances of oocyte pickup. That is a completely different lecture. I'm just trying to take you through how ultrasound can be used at various steps of the whole, management journey of an infertile couple. We all know that ultrasound is, ultrasound guided oocyte pickup is done by all of us. But just a little point over here, always beware of vascularity at the entry point, because if you miss this on 2D, you may not be able to make out that there is vascularity. But if you miss this, you may actually cause vascular injury. And also beware that when you are dealing with oocyte pickup in a patient with endometriosis, try to avoid areas where there is bowel, and always, choose an entry point where you are not going to go through the bowel to enter the ovary. And this is again one very beautiful example of this pickup, which looked so simple, so easy. We went in, we picked up all these follicles. We used the Doppler to pick up all these, follicles. But at the end of the pickup, after pickup, what did we notice? We noticed a large vaginal hematoma. So again, ultrasound is not only used for, doing a safe oocyte pickup, but also for following up patients after oocyte pickup, whether there has been any vascular injury or no. And of course, embryo transfer, my friends, we all know that doing an ultrasound guided embryo transfer improves our pregnancy rates. And if our patients also see the transfer, it gives them, overall confidence and satisfaction. And just a little point over here, ideal time for doing embryo transfer, right from the loading to the transfer, we should keep it less than 2 minutes. And as I mentioned, Applebaum scoring, last 2 slides and we are done, doctor. So Applebaum scoring, again, as I told you, please follow this so that we can actually assess what are the chances of pregnancy for the patient. So as you can see, so much we can do better and see better with ultrasound imaging. And an ultrasound machine is to a gynecologist what a stethoscope is to a cardiologist. I had to really run through the whole, what all I had to convey to everyone, because of how much we can do with ultrasound is just so much that we cannot even comprehend. So I definitely want to say thank you to all my infertile patients who have inspired me to strive harder. And we are having a talk on ultrasound, and this is only and only because of our ingenious engineers and physicists and clinicians and sonographers, researchers, administrators, and of course our commercial enterprises as well. So I think we should salute them and thank them that this diagnostic tool is available to us so that we can treat our women. And thank you to our team as well. Because of them, I was able to gather all this data and present this in front of all of you. And I do not want this to overwhelm everyone. Remember that every expert was once a beginner, and nobody reached elite levels without massive levels of practice, and nobody who did massive levels of practice ever failed to excel. Always strive to be better than what you are. Read, practice, plan. And all of us did not have ultrasound in our postgraduate days, where we could do so much of it before we actually could practice as we are doing right now. So it's only with practice and keep doing it and keep learning, keep failing and learning is what is going to take you this far, that you will also one day become an expert. So that is my message for everyone. And thank you so much. I know I exceeded a bit of my time, but there's so much to convey and so less time, but then I had to convey my messages and just focus on the foundation. Thank you so much, my chairperson, sir, for giving me that extra time. And thank you everyone for this opportunity.
Thank you, ma'am. It was an excellent presentation. I would like to request Dr. Jodha sir to comment on madam's lecture. It was a very helpful presentation, madam, and we have cleared our many of the basic doubts also. I think we'll
sir,
learn. Yeah.
We're waiting for our comments, sir. You are muted. You are muted, sir. Please unmute.
Yeah. You have muted me not to talk in between. That's why I'm not able to. It was a tremendous lecture, Madam Aarti. Has given insight to all the features which a gynecologist should know regarding if really he or she wants to practice, and right from the beginning, like taking a good history and examination part and then proceeding further. And it is nice to watch a gynecologist doing that extremes of infertility workup for these patients to improve the pregnancy outcome. Really eye-opening presentation you have given, and a very nice presentation which can be stored and see it regularly to improve oneself regarding the practice of infertility and teaching the postgraduates. Thank you very much.
Thank you. Thank you so much, sir.
Thank you, ma'am. Thank you so much. Thank you, sir. Moving toward our third topic of today's session, intricacies in the follicular monitoring. I would like to invite chairperson for this session, Dr. Leela Vyas. She is a professional She is a professional senior professor and head of unit, IVF consultant, member of Research Review Board, SMS Medical College Jaipur. She is a senior consultant, Kapun Hospital Jaipur, senior consultant, Aesthetic and Cosmetic Gynecology, Vyas Jaipur, Dakshata and Laksh mentor, and organizing position. She is at present chairperson of Rajasthan 2022, vice president Foxy 2018, president of Rajasthan, President Jaipur OBGY Society, and Secretary Jaipur OBGY Society. Welcome, madam.
Yeah. Good evening, everyone. And at the outset, thank you very much for the MOGS and Aurangabad Society for giving this opportunity. And Dr. Pardesi, I think he has left, and he is always a very as a person who guides everyone. So really, Dr. Pardesi, thank you very much for calling all these in the webinars. And Dr. Sujit, really you have organized this in the fetal medicine. This committee is going to do this thing, and all two lectures really it is needed for all the gynecologists and the juniors. They should know how to proceed that, because now the time is that every time and so many of the infertility patients and so many of the anomalies you are coming across. So if the imaging is very good, then only you can reach up to what you have to decide and where to intervene and where not to intervene. Then the next lecture which is going on, that is the intricacies of ovulation, that follicular monitoring. That she has mentioned everything in the sonography and very clearly see. But now we will listen to our speaker, Dr. Tejashree, and I think this monitoring is the best part by which you can get the good results. So if properly monitored and properly decide that means that decision making, it depends on your monitoring. So now you can start. Actually, I am traveling, so I have that. I can. She's a radio diagnosis and it is she's director and consultant of consultant radiology. Can anyone can read it? This.
She's director and consultant radiologist at Innovision.
So her,
yeah.
So if yeah, definitely, if one of the radiologists, because always we say that you do yourself, but if radiologists are very much interested in this follicular monitoring, then it is very good help to the majority of the gynecologists, those who are sonography. So now I got Tejashree, so please start with your lecture.
Thank you so much, everyone. Thank you, ma'am, for such kind introduction. Thank you, Dr. Sujit. I'll just first share my screen. Can you see my screen?
Yeah, it is clearly seen.
Yes, ma'am.
Okay. So after such a wonderful talks by Dr. Giradi and Dr. Aarti, now at the outset, I would like to thank Dr. Sujit, AMOGS, our Aurangabad Obstetric Society and organizing committee for giving me this wonderful opportunity and making me part of this program. Now I'm going to talk on intricacies of follicular monitoring, the topic which is very close to all the gynecologists and infertility specialist heart. And I hope I will stand up to your expectations. So follicular monitoring is done for a woman who are not getting conceived due to some ovarian factors and they are taking some fertility medications. Now, generally, we want any test to be very simple, faster, and easy to interpret. And it should answer all our queries very immediately. But you know, life is never that simple. So even follicular monitoring is never that simple. It's not only measuring size of follicle, but something beyond that. So let's understand it. So in next 20 minutes, I'm going to tell you how to perform follicular monitoring by ultrasound. What are the complexities we face while assessment of follicles? What are the stepwise approach for assessment of follicle? And what are the key points for decision making for ovulation trigger, IUI, and ovum pickup to achieve good conception rate? And by the end of the talk, you should be able to get all the answer to all these questions. So I will go from very basic. What is ovulation? It is release of egg from woman's ovary and it is key for conception. Now in female having regular cycles, ovulation occurs somewhere in between day 12 to day 16. Now as we all know, There are 4 phases of menstrual cycle: early follicular phase, late follicular phase, early luteal phase, and late luteal phase. So before ovulation, there is going to be a follicular phase, and after ovulation, it's going to be a luteal phase. Now, every woman's menstrual cycle is unique and it follows a general pattern, but length of each cycle can vary according to her age and some other factors. So some females can have a shorter cycle, that is 21-day cycle, due to short follicular phase, whereas few females can have longer cycles, that is 40 to 45 days cycles, because of a longer follicular phase. And that's why even timing of ovulation can vary in between these females. And that can be one of the reasons for them not getting conceived. So to understand the techniques of follicular monitoring, we need to know the detailed physiology of ovulation and how these hormones work at various phases of menstrual cycle. So let's understand it. So as a gynecologist, you all must be knowing this physiology very well, but just to revise, hypothalamus releases gonadotropin releasing hormone, which stimulates anterior pituitary to release FSH, that is follicle stimulating hormone. And this FSH causes follicles to grow. Now, as follicle grow, they start secreting estrogen in the form of estradiol. Now, when this estrogen secretion is at its peak, the pituitary receives positive feedback for LH surge in a short loop, and this LH surge causes ovulation to occur. Now, as we all know, ovary is one of the most active organ of body where cycles are repeated months after months. So the journey of ovulation begins from the late luteal phase of a prior menstrual cycle. When 2 to 5 millimeter size follicles, they are healthy follicles, they are selected from the population from which a dominant follicle is to be selected for the next menstrual cycle. And this process is called as recruitment. Now, during day 1 to 5, process of follicular selection begins when follicles of 5 to 10 millimeter size, they are selected from the recruited pool. During day 5 to day 7, process of dominance begins when the follicle of 10 millimeter size, it takes control. It grows at the rate of 2 to 3 millimeters per day. It becomes a dominant follicle and suppresses growth of rest of the follicles. And during day 12 to day 16, LH surge start to cause ovulation. So follicle that is 10 to 12 millimeters in size, it is called as dominant follicle. It grows and reaches to almost 18 to 24 millimeters before it ruptures. So what do we do in follicular monitoring? It is very simple technique. We assess follicle, growth of follicle on regular intervals, and it helps to document pathway of ovulation to assess morphological growth as well as functional maturity of follicle. Basically, we have to catch functional maturity of follicle and predict time of its rupture. That means we have to find out this golden egg, follow it up, predict time of its rupture to increase rate of conception. And that's why follicle monitoring has become very important component of ART cycle success. Now the question arises, why to monitor the follicles? Because it gives better idea for functional maturity of follicle. It helps in predicting impending ovulation and optimum timing for HCG administration and dose optimization, because this information helps to avoid random HCG administration, which can cause ovarian hyperstimulation syndrome and multiple pregnancies. It also helps for IUI, ovum pickups in IVF cycle. And if she is not ovulating, she can be treated with ovulation induction agents. That is, follicular monitoring helps to individualize medications. That is, it helps to choose the right drug to right patient to increase conception rate and to increase outcome for fertility treatment. So in short, we are going to monitor follicular growth to increase conception rate. Now, the ovulation, it was initially monitored by basal body temperature, mid-luteal serum progesterone levels at day 21 to day 22 and urinary LH level. But because of advances in ultrasound, we are now monitoring ovulation in both natural and stimulated cycle by ultrasound itself. So it is done with the help of 2D ultrasound, color Doppler, pulse Doppler, and whenever required, 3D ultrasound. Basically, a complete cyclical monitoring is done as per baseline scan, pre-ovulatory scan, and secretory scan. Now, this baseline scan is done on day 2 or 3 of menstrual cycle, whereas serial follicular monitoring is started on day 7 or 8 of cycle, which is called as pre-ovulatory scan. Now, out of them, we are now going to focus on pre-ovulatory scan. That is how to do serial follicular monitoring. So, any dominant follicle, it should get matured before ovulation to increase conception rate. And this follicular maturity, it can be assessed by using plasma estradiol levels, but frequent assessment of this blood estradiol, it was becoming cumbersome procedure. So nowadays, ultrasound monitoring has almost completely replaced it has almost completely replaced the plasma estradiol monitoring because it is easy and non-invasive procedure. So with the help of ultrasound, we assess follicular monitoring, follicular maturity by serial follicular monitoring, which should be started by day 7 or 8 of the cycle. Now, generally, women ovulate in mid-cycle, midway between day 12 to day 16. If she ovulates, there is a small window of opportunity, approximately 12 to 24 hours for the fertilization before this egg degenerates. So we have to catch this window of opportunity by monitoring cycle and predicting her ovulation at least 24 to 36 hours in advance to get more accuracy, and it will increase conception rate. So with the help of follicular monitoring, we have to find out a dominant follicle. We have to monitor it till ovulation. Simultaneously, we have to look for the anatomical maturity, physiological maturity of the follicle, and then we have to predict the time of ovulation trigger. So, and you may also get more than one dominant follicle in one ovary. You have to follow all these separately. Now let's see how to correctly evaluate size of follicle. Remember, it should always be done by transvaginal ultrasound because transabdominal ultrasound miss almost 42% of ovarian anatomical details. So, while evaluating ovary by 2D ultrasound, ovary is put in the center of the screen. Zoom the image properly. You can also use tissue harmonic imaging to optimize the quality of follicle so that follicle is imaged as clear anechoic space within. Now we evaluate dominant follicle which are more than 10 millimeters in size. Measuring size of follicle is pretty simple. You just have to measure two longest diameters of the follicles perpendicular to each other. Now this follicle grows by 2 to 3 millimeters per day and reaches almost up to 18 to 24 millimeters before it ruptures. So we have to follow this growing follicle by serial follicular monitoring, either by alternate day to start with, and once it reaches beyond 16, we have to follow it daily. Now, what are the features of mature follicle on 2D ultrasound? The mature follicle on 2D ultrasound is seen as a rounded 18 to 20 millimeter size follicle. It has thin walls with clear anechoic content within. It can have cumulus oophorus, which develops 24 to 36 hours before ovulation. This cumulus oophorus is nothing but a small projection from the wall in the follicular lumen. And studies have shown that presence of cumulus oophorus within the dominant follicle represent mature fertilizable oocyte. Then there is development of sonolucent halo, which appears around 24 hours prior to ovulation, like this. And then there is separation and infolding of layer, which occurs 6 to 10 hours before ovulation. Such follicle is called as anatomically matured follicle. And now we have to assess functional maturity of this follicle. Now, the question always arises many a time, many gynecologists or even radiologists ask that they are not able to pick up perifollicular flow properly. So let me tell you one thing, machine settings are very important for follicular monitoring because follicular flow is a low velocity flow. So to pick the low velocity flow, we have to have a good machine setting. So you have to adjust PRF low, that is between 0.3 to 1.3, and set wall filter low. Now newer machine has newer advances. In many of the premium segment machine, we have very good options available, that is called as slow flow technique or HR technique or MV flow option. The names are different with different companies, and these options, they easily catch a very low velocity flow. So you can use these options also. Now, as far as pulse Doppler imaging is concerned, you have to set PRF low between 0.9 to 1.3 and wall filter is set at 30 Hertz. So coming to follicular Doppler flow studies. Now, as this follicle grows, its blood supply is going to increase, which is reflected in the form of perifollicular vascularity. So this perifollicular vascularity is seen in more than 3/4 of the follicular circumference in a matured follicle. And this is how we take spectral Doppler from the perifollicular vessels. Now, with increasing perifollicular vascularity in a growing follicle, its PSV is going to rise gradually and RI is going to fall. So PSV and RI, they are very important to look for. And in matured follicle, the PSV more than 10 millimeters and RI between 0.40 to 0.48 is considered as optimal. That is called as functionally matured follicle, along with more than 3/4 of the circumference of perifollicular flow. And if these follicular vascular indices are not in defined range, it means that the follicle is not yet functionally matured, and therefore the stimulation still needs to be continued. And 24 millimeters is the size till which we can wait for the optimum flow to be achieved before ovulation trigger. So important points which should be included in ovulation study report are the size of follicle, presence of cumulus euphorus, and follicular Doppler indices. Now, studies have shown that the Doppler findings, they are very much correlated with physiology of ovulation. So, the rise in LH level, it correlates with rise in PSV of perifollicular vessels. So, when PSV of follicle is 10 centimeter per second, it indicates that LH surge has started. Now, when the follicle is said to be functionally matured, when PSV goes beyond 10 centimeter per second, almost 36 hours prior to ovulation. And under effect of LH, perifollicular PSV, it keeps on rising constantly because of increased perifollicular flow, and it rises almost reaches to 45 millimeters per second an hour before rupture. This means that rising PSV and falling RI, it indicates that follicle is proceeding towards maturation. And this is how PSV of follicle is going to increase when follicle gets matured and reaches up to ovulation. Now, in females with known unovulatory cycles, they don't ovulate naturally. So, such ovaries need to be stimulated by various ovulogens to achieve functional maturity of follicle. And then ovulation is induced by various ovulation induction agents like clomiphene or human gonadotropin injections. And these medications can be used alone or in conjunction with IUI. So now, suppose ovaries are stimulated properly and we are in mid-cycle and we have to trigger ovulation at proper time to increase conception rate. So let's see how it helps in decision making. So the end point of any ovulation induction protocol is to identify best time for triggering the ovulation. Always remember, random HCG administration for ovulation induction, it can cause ovarian hyperstimulation syndrome and multiple pregnancies. So we need to be very careful. So the follicular size of 18 to 20 millimeters, that is the leading follicle, 18 to 20 millimeters is considered as optimum for gonadotropin stimulated cycles. whereas the follicle size of 20 to 22 millimeters is considered as optimum for clomiphene stimulated cycles. But these size criteria assess only anatomical maturity of follicle. So vascular indices need to be considered before giving trigger. Now, you must be worrying why these vascular indices are so much important. Because studies have shown that these vascular indices determine ovum quality. If we have low PSV in the follicle, it can cause lower blood supply to follicle, leading to reduced phasic oxygen supply to ovum. Whereas if perifollicular flow has high RI, that is resistive index, that high resistance of blood to follicle causes lower flow during diastole, which also leads to reduced phasic oxygen supply to ovum. And this reduced oxygen phasic supply to ovum causes ovum hypoxia. And studies have shown that embryos produced by fertilization of such hypoxic ova causes there are high chances of getting chromosomal abnormalities in such fetuses. This means that functional maturity of follicle is very, very important to rule out ovum hypoxia. So it's always preferred to wait till desired perifollicular RI and PSV are achieved with same doses of medication in stimulated cycle, even though the size reaches up to 22, and almost 90% time desired RI and PSV, they are reached by the time follicle reaches up to 24 millimeters in size. So coming to IUI, it is preferred method for dysovulatory infertility, idiopathic infertility, and male subfertility. So let's see how it help in deciding timing for IUI. Now, the studies have shown that if PSV is more than 15 centimeter per second, then single IUI can be done 36 to 38 hours after HCG administration. And double IUI can be done between 12 to 14 hours and 36 to 38 hours after HCG administration. And if the PSV is more than 20 centimeter per second, then only a single IUI at 12 to 24 hours can give a high pregnancy rate. So points to remember are: a follicle which grows to 10 to 12 millimeters can be considered as a dominant follicle. It grows at the rate of 2 to 3 millimeters per day. Now, usually ovulation occurs when the follicle reaches to 18 to 24 millimeters in size. The follicular flow can be well detected even follicle starts growing from 10 millimeters in size and its resistance starts falling 2 days prior to ovulation. The rising PSV with steady low RI, it suggests that follicle is close to rupture. The fertilization of follicle with PSV less than 10 centimeter per second, at the time of ovulation, it has high chances of embryo with chromosomal abnormality. An important point is decreasing PSV with rising RI suggests follicle is proceeding towards luteinized unruptured follicle. So to recapitulate, these are the features of matured follicle on 2D ultrasound: rounded follicle 18 to 20 millimeters in size with thin walls, anechoic contents within, having cumulus oophorus, that is a small projection within the follicular lumen which develops 24 to 36 hours before ovulation. There can be development of sonolucent halo around the follicle 24 hours prior to ovulation. There can be separation and infolding of inner layer 6 to 10 hours before ovulation. And on color Doppler, perifollicular vascularity more than 3/4 of the follicular circumference along with PSV more than 10 and RI between 0.4 to 0.48 indicates that follicle is anatomically as well as physiologically matured, and 24 millimeters is the follicle size till we can wait for optimum flow to be achieved before giving trigger. Now, simultaneously, we do evaluate endometrium. We check for its receptivity. Detail endometrial evaluation, it is out of scope of this talk, but in short, we monitor endometrial thickness, we monitor endometrial echo texture, we see whether endometrium is bilayer or bilaminar or trilaminar, or else we can say multilaminar. We evaluate endometrial zonal blood flow as per Applebaum scoring system, and then accordingly we evaluate endometrial receptivity. So what are the features of ovulation? Disappearance of follicle, presence of crenated follicle, and presence of free fluid in cul-de-sac. Now, usually this follicle ruptures within 48 hours after HCG administration. But, this matured follicle, after rupture, it forms a corpus luteum, that is a cystic structure with shaggy walls and ground glass echogenicity within the lumen. But sometimes there is failure of ovulation despite of secondary ovulatory changes in the matured follicle, which can lead to either formation of luteinized unruptured follicle or hemorrhagic unovulatory follicular cyst. And this hemorrhagic follicular cyst, unovulatory follicle, it occurs because the follicle grows so large, and then the capillaries within the follicular wall, they get fenestrated and they extravasate blood within the follicular lumen, which leads to formation of hemorrhagic unovulatory follicle or cyst. So coming to luteinized unruptured follicle, it also occurs because of failure of ovulation. It is seen as a thick-walled structure. There is progressive loss of cystic appearance, and we see luminal echogenicities within. There will not be any free fluid within POD, and on spectral Doppler, there will be a high resistance to flow. That is, we will get low PSV with high RI, which suggests that follicle is proceeding towards luteinized unruptured follicles. And studies have shown that incidence of this LUF, it is significantly increased in patients with unexplained infertility who underwent IUI after stimulation with clomiphene citrate with high recurrence rate. So in this way, if we diagnose luteinized unruptured follicle syndrome, we can use other options for stimulation to avoid recurrent LUF formation, and by this way, we can increase the conception rate. So to conclude, a good pre-ovulatory scan, it helps to catch functionally matured follicle and time of its rupture. It is key for decision making for induction agents in stimulated cycle. It predicts time of ovulation trigger, time of IUI, ovum pickup in IVF cycle to achieve better pregnancy rates. It helps to avoid random HCG administration, prevent OHSS and multiple pregnancies. We always need to keep a standardized ultrasound approach by assessing maturity of follicle. We have to put all 2D color Doppler and spectral Doppler findings together before before having any decision. And this information is definitely help in managing the correct, in deciding correct way for management of such patients. And of course, LUF syndrome, it is equally important to diagnose patients of unexplained infertility because it is very easily treatable condition. Because after all, our aim is to help all the gynecologists to achieve better conception rate, and precise follicular monitoring can definitely help us in doing that. So ultrasound monitoring, it gives better information about hormonal milieu of patient. So extensive hormonal monitoring is no longer needed nowadays. So thank you very much for the patient listening. Please do visit my YouTube talk on complete cyclical monitoring, including baseline scan as well as secretory scan on Indian Radiologist channel. Thank you so much.
Thank you, Tejashi. Means everything you have explained, and if this proper means if any of the gynecologists, those who are not using their own sonography machine, if you are helping our radiologist in this way, the results will be improved, and definitely the final this outcome will be very good. So congratulations for this excellent talk, and really thank you very much.
Thank you everyone.
Thank you, ma'am. Thank you, Tejasri ma'am. It was an excellent talk.
One question is there about this. How long can we see the fluid in POD after rupture of the follicle?
After rupture of follicle, 24 hours.
24 hours. Okay.
Yes.
Ma'am, I would like to
that was
ask one question.
Hmm.
Many times when we are doing stimulation, sometimes the size of the ovum, the follicle, becomes longitudinal. Many times it comes like 24/16, and we have seen failure rate more in those type of,
In such patients,
that
we need to take mean diameter. We need to
mean
consider mean
diameter.
diameter. Yeah.
Okay. So that follicle is it a healthy follicle? Because many a time we have seen a failure with this kind of follicles.
Yeah.
It is a poor quality follicle. That's why it is irregular.
Okay. Thank you, ma'am. Thank you. Any questions from the audience? Let's go toward the end of the session. I would like to thank Dr. Gokul Das sir, Dr. Preeti madam, Dr. Sinha sir, Dr. Rajendra Singh Pardesi sir, Dr. Sujata Darvi madam, Dr. Sujit Konkar for organizing such a great webinar, Dr. Aparna Raul, Dr. Varsha Lahade madam, Dr. Jodha sir, Dr. Leela Vyas madam, and lastly, thank you so much for our excellent speakers of today's session, Dr. Raju Giradi sir, Dr. Aarti Dindayal madam, and Dr. Tejasri Patekar madam for their wonderful presentations. Thank you Shield Healthcare for their educational support, and thank you all the participants. Thank you so much. Good evening to everyone.
Thank you,
Coming to the
everyone.
end of session. Thank you. Thank you so much.
Thank you.
Excellent. Thank you, sir. Thank you.
Thank you, sir.